So I'm just here to talk a little bit today about my PhD project, which works quite nicely with the DeStress project. So I'm looking at developing training for GPs to support them when they're having conversations with patients who may be experiencing emotional problems. And so as part of my PhD, I've been developing this new model of the consultation, which you can see here. But for the purposes of this talk today, I'm going to mostly be talking about the first part of my model, which is creating space for the disclosure of emotional problems. So as we've heard beautifully put in the videos that we've just seen, going to a GP and talking about emotional problems is really, really, really difficult. And so I'm going to talk through a few of the challenges that have come up from my project. There's obviously a lot more, but I'm just going to focus on three important ones for today. So the first one is obviously stigma. So as we've heard a lot yesterday, if you're anticipating experiencing stigma when you go to speak to your GP about emotional problems, then you're significantly less likely to actually be able to talk about those problems. And this is particularly apparent if patients feel embarrassed or ashamed about feeling like they're not able to cope. And as we saw really nicely put yesterday, this feeling of stigma is particularly apparent for patients who may be from low-income communities or unemployed, because you've kind of got that double whammy of stigma that they're experiencing. The second thing that I'd like to bring up is legitimacy, which we've also touched on quite a lot in the last couple of days. So we know that both GPs and patients experiencing some ambivalence about understanding emotional problems as a medical problem or a social problem. And this can mean that patients feel that not able to bring up emotional concerns in their general practice consultations because they feel like that's not the GP's job for them to listen to talk to about their feelings. And this is also another thing that's difficult for patients from low-income communities, as GPs have reported sometimes feeling that what these patients are experiencing is an unavoidable and understandable reaction to difficult life circumstances that the GP themselves is not equipped to deal with. And finally, there's trouble with the interaction in medical consultations. So if somebody asks you, how are you? We all know how we're supposed to respond. You're supposed to say, I'm fine. And we don't leave those social norms of politeness at the door when we go and see our doctor. So that means that when GPs ask us certain things, it can be really difficult interactionally to actually be able to admit feelings of kind of anxiety or depression or stress, because I'm not supposed to do that. So thinking about ways forward, I'm just going to talk through a few of the things that I found from my project that I think might work towards helping with some of these problems. So the first thing is recognizing emotional clues and cues. So like I've just said, it's really difficult to be able to just come out with it, that you're struggling. And this is what's known as troubles resistance. So we're not supposed to complain. That's like the social norm that you're supposed to be seen to not complain. And then also the legitimacy problem, is the GP the right person to talk to about these issues? So that means that patients often hint about feelings of emotional problems, and this indeed has been found to happen in over half of general practice consultations, both physical and mental health consultations. So what do these clues look like? These are a few examples. There's obviously loads more. So you can get what's called a downgraded conventional response to inquiry. So we all know we're supposed to say fine if we're asked if we're okay. If you say, oh fine, I guess, or yeah, I guess, this can be like a big red flag saying this person is not fine, and perhaps maybe that's worth looking into a bit more. Clues often also come out in physical examinations when the doctor is not talking, so the patient can then bring up emotional concerns. So say if you're having your blood pressure taken, that's the time where patients will often come in and start talking about these worries. And also clues often come out as general expressions of frustration. So when you're noticing these clues, this is a good opportunity to ask patients questions about their emotional concerns, and this is the next thing that I'm going to talk about, is how to effectively ask questions of patients. So we all know from also conversation analysis that questions have three main components. Questions set agendas, so if you ask a question, that means that the thing that you've asked about, you've decided is relevant to be discussed in that conversation. You ask a question from a knowing or an unknowing stance, and that shows in the way that you ask the question. And then also questions are designed to give a preference for a yes or a no response. So you don't need any help with washing up, do you? That means I want you to say no. So we can turn these around in these consultations to help ask more effective questions of patients, which will make them more able to bring up emotional problems. So by asking a direct question about their feelings, this puts emotions on the agenda, and that nicely bypasses the legitimacy problems that I mentioned earlier. You can also ask the question in a way that makes it easier for patients to give an affirmative response. So I'm sure many of the people who've been to see their GP about emotional problems have got the "you're not suicidal" question. And that makes it really hard to say, yes, you are, if that's what you're feeling. So there's a way we can turn that question around to make it easier for you to be able to admit to things that actually are quite difficult to talk about. And finally, which Rose and Richard discussed, is attentive listening. So there's many studies that have been found that if patients perceive their GP to not be paying attention, so for example, if the GP is paying attention to the computer and is turned away, the patient's going to really struggle to articulate the things that they're concerned about. And this is really easy to kind of rectify. So there's been a lot of research to show that eye contact and attentive posture, allowing patients to speak, like we neatly saw in that consultation video earlier, and that's all associated with significantly increased identification of emotional problems. Turning to completely face the patient with both parts of your body, that also is associated with a fuller problem presentation. And finally, using things like, I see, yes, can give the patient space to fully extend what they want to say to you without being interrupted halfway through. So this is the bit that's always difficult and that I get pulled up on a lot, and it's come up a lot in this project, is how we don't have time to do all of this. But the thing is, these consultations, if these clues are missed, if patients aren't able to bring up their emotional concerns, they actually take longer because patients will keep trying to get them onto the agenda. But the most important thing is, doing this is all related to improved patient symptoms. So actually, this is helping people get better. So recognizing emotional clues gives you a better relationship, which we know is intrinsically therapeutic. Patients report valuing the quality of the time they have with their GP over the amount of time they have. More listening interactions is associated with higher patient satisfaction. And overall, this good relationship that all of these things develop has a therapeutic benefit that has been reported to be over the effects of antidepressants. So what I'm arguing with my model is not to add in things to GPs who've already got very stretched resources, really busy, a lot of things to do in consultations. But it's like what Richard was saying earlier, is taking the focus away from feeling the need to fix patients and focusing on things that have been shown by evidence that are really valued by both GPs and patients, but kind of a little bit fuzzy and a little bit difficult to pin down. So I'm arguing that we can take some time away from the treatment recommendation phase, which we saw yesterday can be a little bit sticky when there's kind of this negotiation around treatments that patients might not want to take, and give that time at the beginning to give a full understanding of what the patient's problem is, and then spend that time developing that shared understanding of the problem, and then work together, perhaps maybe in subsequent appointments, to develop a plan of action of where to go next. So just to summarize, non-disclosure of emotional problems is more complicated than patients simply withholding their concerns, and this is particularly challenging for patients who may be from low-income communities. Simple techniques such as recognizing and responding to clues, effective questioning, and attentive listening improve the disclosure of emotional problems. And most importantly, all of these things are therapeutic in their own right. Thank you very much.